Thank you. Good morning, everybody. Good morning to all our guests that are joining us today. I know we've got guests as per normal from Health Watch and trade unions and a number of our staff that are coming along for their own development and interest. You're very welcome. And as ever, if anything comes up during the meeting, then following the meeting, I'm sure that anybody you see on the screen would be able to answer any questions that you may have. Welcome to any members of the public that may be viewing us either live or on YouTube. This is the board meeting in public of Herefordshire and Worcestershire Health and Care NHS Trust. If we do a couple of specific welcomes, please. Welcome to Colin Horth, who has just recently joined us as an Associate Non-Executive Director. It's Colin's first meeting. You're very welcome, Colin. And also, you probably won't expect this, but Scott Parker, welcome to your first meeting in your substantive post as Director of Improvement. Again, you're very welcome, Scott, although I know you've been here a number of times in a secondment position. Jill tells me that we have no apologies for absence. Can I just check that is the case? Okay, seems to be the case. So, which moves us through to the meeting, the minutes of our meeting held on the 18th of July. Does anybody have any matters arising or matters of accuracy they wish to raise? No, in which case we'll take that as a true and accurate record of the meeting. Thank you very much. On the action log, we have two matters. One was a question from a member of the public, which has been responded and sorted. And the other one, is there an update there? Has somebody spoken to Sue with regard to children, young people? Sue, has that taken place?
It hasn't, but we're having a conversation this afternoon.
Okay, then, so we'll leave that open and then close it off once that's happened. Thank you, Sue. And I'm led to believe, Jill, that we have item number 6. We have a question from a member of the public.
Yes, we do. So, can the chair of the board give absolute, complete and unconditional assurance that no confidential or privileged information, whether written or not, has been provided to any external organisations, for example, charities like Onside Advocacy, St Paul's Hostel or Worcestershire Association of Carers, to the management board of Worcestershire VCSE Alliance, that could give an individual or group of individuals or organisation in receipt of a competitive advantage and violate the principles of fair competition and commissioning regulations?
And I think it's appropriate, as it's addressed to me, that I can answer that question, and I can confirm, to the best of my reasonable knowledge and inquiries, that no trust held and owned confidential or privileged information, written or otherwise, has been provided by any board member, directly or indirectly, to any external organisation or individual for any purpose. If we now move on to declaration of interest, which I know are published on our website, and I reiterate, if anybody has any declarations that change, please inform Jill as soon as possible. I assume there are none specific to today's meeting. Nobody's showing, so thank you very much. Which then moves us to one of the most important aspects of our meeting today, which is the patient story. And I'll hand over to Natalie, because I believe we're to have a video first. But Natalie, to introduce. Good morning, Natalie.
Morning, everyone. Thank you. And welcome to Rachel, who's joined us this morning and is going to talk us through the service. But continuing the theme of recognising the work of some of our allied health professionals, we have a patient story. We've recorded 3 people for this patient story. So I'll hand you over to Fee, who's going to share that with us, and then Rachel's going to talk us through the service. Thanks, Fee.
Thank you.
My name's Paul Late. I'm 59 and have suffered with my feet for the last 25 years. I'm under the local community team after being referred by my doctor. They're an absolutely amazing team. Lisa, Nicola and Kirsty. They have never let me down. My appointments are always on time and they always try and arrange appointment round whatever I'm doing, which is absolutely brilliant. Approximately 3 months ago, nearly 4 months ago, my foot swelled up and an ulcer appeared. I was sent the email to the multidiscipline team in Kidderminster. The secretary contacted me back and I was seen within 24 hours. Following on from that, Vicky, who is part of the team, thought that I had Charcot foot, so she brought me into the actual Kidderminster Hospital on the Thursday to see the specialist, Mr. Pereira, and he actually diagnosed Charcot foot. So between Vicky and Jill, I have been treated so amazingly to the point that there was times there where I could have lost my foot quite easily. They were very open and they told me that could happen. So all along, they've been very honest with me of what I've needed to do. The dressings, I was seeing them twice a week. And to be honest, without the podiatry team in Worcestershire, the county would be lost. This team is absolutely fantastic and have saved my foot.
Hi, my name's Gwyneth, and I've got a few conditions that affect my feet. Diabetes and systemic sclerosis are the main ones, and I've been treated by podiatrists for some years now. I really have only positive things to say about the podiatry service. I've been treated by different podiatrists at Prospect View, at the John Anthony Centre, and at various hospitals, including Worcester, Kidderminster, and Redditch, and I found almost all of them to be polite, friendly, knowledgeable, and respectful. When I say almost all, there is one who speaks to me as if she is superior, several times disregarded my opinions, which are based on my own experiences. She makes me feel as if I'm an inconvenience to her. I feel that she would benefit from further training, both in podiatry and in patient interaction. But of course, that is only based on my own experiences. Anyway, on to the positives. The office team based at the John Anthony Centre are excellent. They always try to find appointment times that are convenient, and they're always cheerful and helpful. I shouldn't pick out particular people, but I just have to say that Joe is particularly pleasant and always helpful. All of the podiatrists have been friendly and helpful and knowledgeable. I've been referred for various further treatments, such as orthotics, and for surgery, and even once to A&E when Claire Merton told me to go immediately to A&E, and therefore prevented the sepsis that was just starting from getting any worse. I was admitted to hospital on IV antibiotics, and a planned operation on my foot was brought forward. I'm now on IV antibiotics at home, so thanks to the podiatry team and to Mr. Pereira for this. Claire has been excellent for all the time I've been seeing her. She's totally dedicated to her patients. And we do get talking in the waiting room, so I know that other patients respect Claire too. Claire is not only knowledgeable and efficient, she also has a positive attitude and puts me at my ease. The other podiatrist I'd like to mention is Andy, although Andy always presents as cheerful and sometimes self-deprecating. His treatment is always excellent, and he too is knowledgeable and professional. So to sum up, although I've had to spend a lot of time having appointments with the podiatry team, the waiting times are rarely long and the whole experience is rarely an imposition. The team work together as a cohesive whole, and I do recommend them. So thank you.
Hi, my name's Gary Mealand. Everybody knows me as Grumpy. In 1994, I started to get diabetes, and it was quite bad because I had a sugar addiction. Own fault, not worried. But it's backfired on me now. I contracted Charcot through a foot injury on my right foot, and I should have lost the foot back in 2010, but I was determined to keep my leg. But through the diabetes, I started to get ulcers, neuropathy, everything that diabetes does to you. I more or less got it because my immune system as well. It's got to a point as we got on that in 2016, the Charcot contracted cellulitis. Again, I nearly lost the leg, but look, somehow I kept it. Downside was I had a mini heart attack while I was in hospital, but that's, don't matter that. I'm in a situation now where I've only got one leg, due to the fact that I contracted sepsis from the injuries I had in my foot. I didn't take the advice of the MDF teams at Worcester Hospital and John Anthony Centre and Prospect View and even Upton Surgery. The downside of that is that if I had took the advice of them, the team were looking for my best interest. Stupidly, being stubborn, it backfired. So now I'm waiting to get a new leg. I contracted sepsis last year, and it really knocked me for six. I went from a bubbly person who was full of life to a shell. Even the people where I live used to say I looked like Death Wonder. I was grey, there was no energy in me. But the MDF team and Dr. Bourgeois and Dr. Pereira and all the gorgeous ladies that look after me never gave up on me. Me personally, I would have given up on me. They didn't. I went to Worcester Hospital in February this year. The consultant, Alex, looked at me and immediately got me into hospital. 2 days later, I had a left below the knee amputation. Now I'm living with that problem. But it's not put a dampener on me, it's actually improved. I'm now not 100% better, but my right foot has healed. The Charcot will never heal, I know that. But I used to have a 1-inch deep hole in my right foot. That's healed completely. There's just a little blister there now. As for the diabetes, that's more or less controlled better than it was. It's still high, but I know why. Whereas before, I didn't. I'd love to name every single person in the MDF team that's helped me, but due to a stroke, I forget names, even when I see them regular. So, yeah, my advice to anyone that ignores the team, don't. Listen to them because they'll save your life one day. They did me. Thank you very much.
Thanks, Fee. I'm going to hand you over to Rachel, who's now going to talk us through the service that Paul, Gwyneth and Gary outlined that they'd received there. So thank you and welcome, Rachel.
Morning, everybody. I'm just going to hopefully share just a quick PowerPoint. Can everybody see that?
Yeah, that's great, Rachel.
Hi, morning. So my name's Rachel Gibbons. I'm one of the integrated community service leads. So I actually manage the MDFT, which is the multidisciplinary diabetic foot team, and the podiatry service as part of Hereford and Worcestershire Health and Care Trust. So for those that you aren't aware, the podiatry service in Worcestershire consists of 3 community podiatry teams who provide treatment and assessment to those patients that are most at risk of foot ulceration and infection. And we also do a large bulk of work on minor surgery for the ingrown toenails. There's also a county-wide musculoskeletal service, and these staff diagnose and manage patients with foot and ankle related disorders. And then there's the county-wide multidisciplinary diabetic foot team. And this is the team I want to focus on discussing today, where the patients have just spoken about their experiences within the team. So a bit of a history, really. The MDFT was actually launched as a service and given some temporary funding back in 2017 by NHS England. We had a peer review conducted by NHS England of the service in 2021. And actions were recommended by NHS England, and most have been successfully implemented. Now, on the back of that, following that, the ICB has secured commitment to the long-term future of the MDFT, and that happened early 2023. So what does the MDFT do? So we provide urgent assessment and advice on the management of patients with active diabetic foot problems. So it's where we need that combined assessment and that MDT approach to that care for that patient. So we have a highly skilled team of podiatrists within that team that work in partnership with the wider members of the MDFT. Now, these include the vascular consultants and their team, the orthopaedic consultants, the acute diabetic specialist nurses, the diabetology department, the orthotist, the OPAT service and microbiology teams. The aim of the service is to provide that rapid access to care, usually within a 24-hour period in those emergency and urgent situations. It's really vitally important to think that these patients are seen urgently. We've heard those stories there. They are at the greatest risk of lower limb amputation, infection that can lead to sepsis and Charcot foot, and the long-term health and social impact that these have on patients can be devastating. As podiatrists, we provide the necessary treatment and escalation and admission if required. We also, as podiatrists, support the diabetic foot MDT clinics at Worcester Royal Hospital, where patients are seen alongside the vascular consultant, orthopaedic consultant, orthotist and DSN. I think in addition to this, I think we need to realise that actually the podiatrists across the county also provide clinical support to up to 9 consultant-led clinics per week in vascular and orthopaedics. And we are actually the only MDFT in the country, as far as I'm aware, definitely in the Midlands network, that provide on-call working at weekends and bank holidays to ensure that we are responsive to these urgent referrals for these patients. And a collaborative working between the acute teams, the MDFT and the community podiatry teams has so greatly developed over the past few years. And that's really due to the hard work and commitment and the dedication of these staff in the care and management of these patients to help create and develop this service and develop these clinical pathways. So what do we look at? So our main overall aim with the MDFT is to reduce or maintain the amputation rates for both minor and major amputation due to diabetic foot disease. In the past 12 months, we have seen a 15% reduction in minor amputations and a 38% reduction in major amputations that have been reported in Worcestershire. We assist to help reduce the number of inpatient bed stays related to diabetic foot disease by providing that early and rapid intervention to those patients. And we aim to reduce the admission rates into secondary care. The MDFT, we also ensure that we collate and submit data as part of a national diabetes foot audit, so we are benchmarked against other organisations. And we also complete RCAs on all the major amputations that occur, and that learning is widely shared. And we discuss regularly as a team all our key performance data. I'd just like to share some of the challenges that we face as a podiatry service over the next now. Workforce, we know the AHP profession, it's very hard to recruit to. We have done a lot of work locally in Worcestershire. We have just had our first apprentice qualify. We've got another one that's starting in year 2. We have facilitated return to practices. We've been involved and went to South Africa on an international recruitment for the Midlands region. We get ourselves involved in career workshops and looking at skill mix across the workforce. I think there's been a reduction in our ability to provide that preventative foot care services due to that upsurge in demand on the podiatry teams for those complex foot wounds and ulcers. EPR systems, when working in a cross-organisational MDT, there are far too many EPR systems to access and navigate on a daily basis. The MDFT and podiatry service is in scope for the AHP integration work stream. And also self-referrals. The MDFT do accept referrals, self-referrals, so we ensure that they are seen urgently. There is an initiative at the moment to open up self-referrals to community podiatry teams. I'd just like to, I'll stop sharing that. I'd just like to thank the people that spoke, our patient stories, Paul, Gwyneth and Gary, who shares their experience with the podiatry teams and the escalation into the MDFT. I think it really sort of highlights to us how far the service has developed over the past few years, and that collaborative working that is happening now across the system for these patients. Being able to escalate these patients quickly into our colleagues in the wider MDFT and the acute teams. I mean, me personally, I've been involved in Gary's care since I joined the MDFT 2 years ago, and I think his story is really telling of the impact that disease and the effects of our service not being there for patients and the devastation it can have on their lives. So thank you very much.
Thank you very much, Rachel. Thank you, Natalie, as well, because colleagues will probably notice Natalie's trying to introduce a different way of bringing patient stories forward so we can see more patients. Hence, you see the video with 3 patients as opposed to the sort of normal one in person. So following the meeting and at any stage, I'm sure Natalie welcome feedback on how this has gone. OK, then I've got a number of people showing, so I'll take it in the order that I've seen. So we go Janet and then Sue, please.
Yeah, thank you very much, Mark. And thank you, Rachel. I thought that was really, really interesting. And I'm always absolutely amazed at how articulate our patients are and can be, and the insight that they give into actually what it is like being a patient in one of our services. And I think you should be really proud of the things that they've said, and I'm sure you'll be passing those on to the team. My question's about the whole multidisciplinary thing, because it's ideal, isn't it, for patients? It wraps around the patients and it's what they need. But I think we need to recognise that multidisciplinary team working is really difficult and time consuming, and that can be within an organisation. So I think to actually work across organisations in that way is very impressive. And I just wondered if you've got any learning that you could share with us on, you've made it sound, you haven't made it sound easy, but I mean, you've painted a really, really bright picture of how it's working. So learning that we could have as a board for other services to work in this way.
Yeah, I think it's come with its challenges. I joined the MDFT 2 years ago, so I wasn't there at the start when the funding was initiated from NHS England. We've had to look at some of the challenges. it works in a way, that hub and spoke model. When we look at other models that other organisations look, the MDFT is usually a secondary care based model, so it's hospital based. We have a hub and spoke model, so we as the podiatrists sit within the community trust. Now that makes us in a way reduce those health inequalities, because actually some patients can't attend quickly to hospital situations. It allows us to flex a little bit to actually go out to these patients that might be on mental health wards, they may be in a community hospital, they may be in a nursing home or a care home, and it allows us to remotely liaise with the wider team and formulate that care plan for that patient. It has come with challenges, and I'm not saying it hasn't. I probably have painted a bright picture, but we've had to work through a lot of those challenges. But that is on the basis that we want the best for the team. We work in a fast-paced environment. We have to deal with these referrals very, very quickly and get them turned around very quickly to ensure that those patients receive the right care at the right time.
Thank you, Rachel. Sue and then Vina. Sue.
Thank you very much for that. It was very, very interesting. So you've partly answered this by talking about the hub and spoke model, but I wanted to know, are there particular patients who are hard to reach, either geographically or because of some protected characteristic, which you would like to sort of really focus on?
Yeah, geographically, I mean, we all know that the county is a very wide county. So we change our timetable on a weekly basis to manage the caseload and the referrals that are coming into us. We have to be responsive in that way. We do a lot of remote working out with the neighbourhood teams who can outreach these patients very quickly for us as well. We have links with Forgotten Feet, which work with the homeless charities in the area. We have podiatrists that volunteer, so we make ourselves very aware to these communities, these people as well, that they can access our services. Translation services are always used as well for our patients. So we try. Yes, there are difficulties at times.
When I visited, I heard that the translation service sometimes let you down. Has that improved?
It has improved, yes. So we tend to be able to phone in now just prior to the appointment time, and we tend to have them on a loudspeaker rather than them come face to face, because that's when they were letting us down. So we do it through telephone most of the time now.
Thank you, Sue. If we move then to Vina and then Martin. Vina.
Thank you. Rachel, we heard from Gary how important it is for patients to follow the advice they're being given and the catastrophic consequences of not doing so, which makes it all the more important that our staff are supportive and empathetic and encouraging. And it was really interesting and actually really helpful to hear Gwyneth's experience, that occasionally she comes across members of staff who don't display those traits. Do you feel, Rachel, that you have the tools and the support to address those situations when you come across, staff members who are perhaps not displaying those traits? Do you feel that you have, the mechanisms and the procedures available to tackle those? Because it's yet another thing on your list of very important things you've got to address, right?
Yeah. So locally, we would have to address those locally within the team. So it would be through their supervision, their one-to-ones. I have spoken to the member of staff, and I've advised that maybe we do some additional mentorship. So she sits in with other clinicians with these patients, and we work more alongside people. So we have made a plan, but they, like you said, they are more local to your service, and I presume they would differ on the approach from one service to another. I feel, because I am quite present within the team on the ground, that I have a good relationship with my staff and I am able to have those conversations. But I wonder in other teams that are larger and don't have visibility of, say, their team leads or managers, whether that would be addressed. And move then to Martin, and then following that, Beej having some issues with some audio feedback. So there's he's put the question in the chat, which I'll then bring to your attention, Rachel. So you don't have to go looking for it. Okay, Martin.
Yeah, thank you very much. I just want to pick up, actually, Sue and Vina have touched on this, but the point around Gary saying the MDT didn't give up in terms of continually providing the right advice, etc., but he ignored it. And I wonder what tools you feel you have available to go outside the MDT, outside the clinical sphere, to influence people, because I think there's a challenge for us as a board on a wider piece in terms of our health inequalities group, that the more you go into inequalities, the more you have to spread beyond the clinical to engage and give advice for people who are nervous of that, of clinical intervention, state intervention type things. And I wonder how you feel equipped to do that, and what would be helpful for us to be thinking about providing.
I think it's more about clinical awareness of patients of the risks associated with diabetes. We luckily got some money commissioned through the ICB last year to commission some educational videos around the risks, because time and time again we have patients come into us going, I didn't realise that there was a risk that I would lose my foot. And it's a hidden disease, diabetes. They don't understand the damage that is being done by that poor control. So I think it's going back. I would like to go back to primary care, really, because they are the ones that provide the foot risk assessments. They are the ones seeing those low to moderate risks. And I think that education needs to be pushed back to primary care to ensure that they are getting to the diabetics as soon as they are diagnosed, to ensure that they are aware of those future risks. Because by the time they come to us as a service, they're already at risk. So I struggle at times with getting that message through to primary care. So if I could have some support with that, that would be really useful.
Thank you.
Okay, just to follow up just on that one, would you know where to go to ask for that support, Rachel?
I usually go to the the ICB link, who's the long-term health conditions. I usually go to her. We have diabetic MDT meetings, and we used to get GP representation, but unfortunately the diabetes champions are no longer present, and we don't have that primary representation at those meetings.
Okay, well, you've made that point to all the right ears on the screen here, and I'm sure somebody like Natalie would have picked that up, and perhaps we can feed that back in. Natalie, John, through the various clinical forums that we have, we can try and feed back in if at all possible. I see nods on the screen. Beej asked a question of you, Rachel. Beej is a non-executive director. He says, you mentioned the MDFA audit that shows how we're performing versus national teams providing similar services. How do we rank? And what one or two things could really change the dial if you had sort of a magic wand?
Yeah, so we've done a lot of work this year, because the only wounds that we were inputting were the ones seen by the MDFT, the more complex wounds. So our healing rates were below the national average, our 12-week healing rates for diabetic foot ulcers. This year, we have actually implemented the SNOMED code. So we are now inputting all the diabetic foot ulcers that are being managed by the community teams as well. So the NDFA has landed this year because the yearly audit results, our improvements, we are now slightly above the national average on our benchmarks, which is brilliant.
You on mute, Mark.
Thank you. Any two things you may wish to change, or anything you wish to change which would really help and shift the dials at all? I know I've put you on the spot, or B just put you on the spot, but
I think we could improve efficiencies. We work so closely with the community neighbourhood nursing teams who, like I mentioned in there, they manage a lot of these patients for us. We are not on the same EPR system, and it's a real challenge for us. We duplicate so many assessments, so much work, and it would really help with efficiencies. And then knowing what our care plans are for these patients once they've been seen for the MDFT, because they have got no visibility of them.
okay, thank you very much. And John's just come in. John, did you wish to comment on that?
Just on the previous point, Mark, so just for information for board members, the ICS long-term condition strategy, the first time it's been developed, it's live now. It's been signed off at the place board, I think last week. So Rachel, it might be really helpful to feed in what you just said about the primary care interface into that, and take that forward with the strategy work.
Thank you.
And then Rob, before I then bring this to a conclusion, Rob.
Thanks, Mark. Rachel, I put something in the chat. I wonder if we could touch base after the meeting on the two aspects about the primary care interface, but also with the neighbourhood teams and the nursing components. So I can think of a couple of forums where if we could get you along with the right people, we could look at some of those issues and look at how we could try and make some improvements. So let's catch up after the meeting. It'd be really great.
Thanks, Rob.
Thank you very much. Now, I know one of Natalie's intents of bringing along AHPs and some of the more hidden services to us is to raise the profile and raise our understanding of these issues and the problems and challenges. Wow, have you done that this morning, Rachel, for us? You really have. And of course, with Paul, Gwyneth and Gary's assistance. And just some comments, if I may. Firstly, thank you to you and the team. You've done a great job this morning in raising the profile and bringing the issues to us. And as you can see, by raising a couple of issues, you've immediately got got the ears of the people that can make change and affect change to make you and your patients a lot better. So let's hope that happens. I had the privilege, I'm not sure if you're aware, Rachel, I had the privilege of spending a morning in Podiatry Clinic in Redditch. I don't know how long ago it was. Which was fascinating with the patient's permissions, obviously, and it opened my eyes to a few things. One was the complexity of the issues that you and your teams are dealing with, and two, and this was raised, I think, by Gwyneth, how people feel when they leave the clinic. Now, clearly, Gwyneth on occasions had a poor experience, and it made her feel not so good. But I saw people leaving that podiatry clinic, and perhaps, I don't know, perhaps it was the only person they'd see that day, maybe that week. And they were leaving with beaming smiles on their face because of the way they've been interacted with, because of the way they've been treated in that social interaction. So it is so much more than just the actual, if you like, the clinical interventions. It's actually the human interventions that take place as well, which can help our patients. And it was so impressive, because I know that many of these patients, you have long-term and enduring relationships with, don't you? It's not like often in an acute trust where it's like a 2, 3, 4 day and then off they go somewhere. It can be many years. And so it's an impressive service. It's often a hidden service. So thank you, Natalie, for bringing it forward. Thank you, Rachel, for doing such a fabulous job today. And please pass on your thanks, our thanks as board to all your staff. You're doing a great job. And if you thought you were hidden before, and I think that was the comment that left me in the in the Redditch clinic, they thought they were rather hidden from everybody. You're certainly not hidden now. So thank you very much for attending.
Thank you. Thank you for your time.
Okay, thank you, Rachel. You're welcome to carry on joining us, but I suspect you've got other things to do.
I've got things to do. Thank you.
I guessed as much.
Have a good day.
Okay, thank you. And
bye.
Natalie, thanks ever so much. I think that format worked quite well today, so I know we're gonna see more of that, and we can discuss that. Okay, let's move on then to Robert's report. Robert.
Thank you, Chair. Thank you, Mark. Thanks. The opportunity to just run through some of those key items and events that have been happening over the past few months. I was just going to, before I start on that, just reflect on, I thought that was a really, really helpful patient story we had there, and we'll pick up outside. But personally, I thought that was really, really great, and my thanks to the team for what they do and bringing that to our attention. So just turning to my report and what we have there. Actually, the first item isn't in the report, but it's a really important one. This was due to timing, so I think colleagues will be aware of the publication of the Darzi, Lord Darzi review into the state of the NHS. That is a really important report that's just been released. I know colleagues are aware of it. I'll just note it, particularly for any observers, that there's some really important information in there. Just to set the context here, really, clearly there's an element here around drawing out some of the political messages and so forth, but it is a forensic review of the overall performance and quality of the NHS as a whole. And I think when you draw all of that together in one place, there's probably quite a sobering view about where we find ourselves. Clearly lots to do to improve, lots to do to get towards those national and constitutional standards that we have. I guess the second part of it is really the diagnosis of where we see some of those significant barriers or things that have happened over the past 10, 15 years that have particularly led us to where we are. And that's very much going to form the basis of the exercise that's going on at the moment, which is running to draw together that 10-year plan for the NHS, which we're expecting in the spring of next year. So the Darzi review very much being the diagnosis of where we are, and then the plan being the prescription of how we take that forward. A few other key events that are happening around that. Clearly, first one is that there is a comprehensive spending review that happens in the spring. So that's cross-departmental. That will line up with the 10-year plan. Ahead of that, we have some important events that are going to happen around the autumn spending review, but that's going to be more short term in terms of how that deals with things. And I guess the other overarching message that's there is we are where we are. We have quite a difficult position to get through in terms of managing through for the remainder of this year. And you'll know from the reports that we have, particularly some of the reports from my team, Matthew's operational report, Denise's finance report around some of the challenges that's bringing. But I think that's a really important bit of context. We will bring through more of that through either governance in terms of internal committees or up to board, just as we work through some of that detail. So just turning to the report then, the key points I wanted to draw out for you were, first of all, clearly we had some really significant and disturbing events in the summer over August around civil unrest, and we were particularly mindful of the impact on our staff and how that makes some of our staff feel about going about their day-to-day lives as well as delivering care. We've been doing some work just to really reiterate the position of the Trust. We all know that we have work to do in terms of moving towards a much more inclusive organisation. And I think from the civil unrest, that probably just brought home to us we have got work to do. So thanks to my colleagues who've particularly been stepping into that space and helping raise awareness. My thanks to the network, the Enrich network we have, for working with us on that as well. Some really important stuff there that we need to do, which we're not getting right at the moment, but we are working hard to get better at, and we will do so over the coming months and into the medium term as well. So I just wanted to draw that out. I think that's really important for board to hold on to. Again, in my report, actually on the same page, we had a really important report from the CQC, the special review of rapid review of Nottinghamshire healthcare. Some really important work that we need to do and some learning that will come out, not just for ourselves, but for the NHS as a whole. I'm not going to dwell on that because Matthew's got a slot in his report around the review and the self-assessment we need to carry out, particularly around the intensive and assertive community mental health services. But just to note, there's a really important piece of work we're doing with the ICB, some deadlines at the end of September. We'll be drawing some stuff up through our governance and then onto board. Matthew may well expand on that a little bit later on. Just going a little bit further then into the report, and again drawing out key theme. I draw out the theme around industrial action. Again, events are moving on at the moment, quite a lot in the national media today, clearly around the junior doctor's position. The report particularly references the position with primary care and GPs. Again, Matthew will probably pick up in terms of how that is affecting our services in his report a little bit later. I would just draw out the theme here. I think it's enormously helpful from a service perspective that we are moving to the point where we have resolution of some quite long-standing industrial disputes. We're hoping that we will get to the point where all of those are resolved and we can then crack on with drawing a line under that and remediation, recovery of the overall service, which I talked about at the start in terms of what's set out within the Darzi review and as we move into the 10-year plan. So some really important stuff there and really encouraging to see that we're moving forward. Again, another theme I want to draw out, but it's in the report as well. And again, not to be a stuck record, I'm sure Matthew will touch on some of this, but winter resilience is hugely important. The planning is well underway in terms of how we work through that. We're working closely with system partners, is what I would say here, particularly acute colleagues, but not forgetting social care, primary care, ICB colleagues. Again, Matthew and Rob may touch on a little bit of that later. I couldn't pass over the point about pay awards, which is clearly hugely significant for our fantastic staff. We're expecting those to be passed through in October, and clearly we're just seeing some other elements that are coming through in terms of resolution, industrial action. We're hoping that works through smoothly and provides some comfort for our hard-working staff. Towards the end of the report, we have the reference to the SEND review, which was clearly a significant point for Worcestershire. So this was a joint review by CQC and Ofsted into particularly the SEND services, but gives us some wider learning in terms of children's services as a whole. A lot for us to do as a system. We're one of the key providers within that. Clearly the report is particularly focused and addressed to our commissioners, so that's the council and ICB. And for those of you that will have dipped in and been aware, this was quite a focus point on the ICB meeting yesterday. We're working very closely with our colleagues to work out how we improve that, particularly for us, focus on waiting lists and clearly capacity and some elements of how we listen to our patients, listen to their carers and redesign services to address some of those concerns. So some really important stuff there. And then the final part I was going to just draw out, Mark, which we've already referred to. So just to note, I've got the formal notification or noting there that we've got those board changes. I know there's an awful lot there. Actually, the report's a little bit longer than usual. There's quite a lot in there, but I'll pause there and happy to take questions.
Any questions then? And we'll start with Colin. Colin, welcome.
Thank you, Chair. My camera keeps switching itself off, so if you lose vision, it's nothing I have to apologies for that. But Robert, thank you for that very comprehensive review. As a newbie, that's helped me get up to speed very quickly. But as you might expect, one of the areas I'm particularly interested in is the impact on this trust of the SEND review. From my experience elsewhere, there is widespread concern that there is a latent, unrecognised demand among children and young people due to the impact of COVID on all sorts of their well-being, but particularly mental health. So if we already have issues around waiting lists, is it a concern that there's potentially a surge coming our way?
I'll just a few words, and then I might draw Matthew in, who's very close to this and leading on the work from a trust perspective with partners. I think Absolutely, in terms of that specific part, Colin, we are seeing an uptick in referrals and activity arising from how we managed through COVID. I think it is broader and more complicated than that as well, though. So the point I would particularly draw out is I think those community services, and this is recognised in the framing from the new administration about a desire to really focus on improving capacity within the out of hospital setting, so primary and community capacity, and we're seeing a combination of that as well as the the consequence of how we've managed through with COVID. Matthew, do you want to add a bit more detail and colour to that?
Yes, absolutely. So as Robert said, before we went into COVID, I think our situation with our community paediatric service, all our community services for children, was that they were stretched. They were at 100%. Some were slightly more than 100%. As you quite rightly point out, after COVID, it quickly became clear that the demand for many of our children's community services was far greater than our capacity to provide that. We've been working with system partners, I'd say slowly, for the past couple of years. I think the SEND report has shone, for me, a welcome spotlight on some of the challenges. So particularly the SEND report highlighted for us the long waiting lists for children waiting for physio, OT, and especially neurodiversity assessments. Since the SEND report, we've been working with the ICB around an investment plan. We've agreed around £900,000 worth of recurrent investment into services. We've had a further discussion this week about more sustainable investment, especially into the neurodiversity pathway. So work is ongoing. What I would say is that we've got some waiting list initiatives that we've started to try and tackle the backlog of children that have been waiting a very long time, but this is a longer term plan. So getting us onto a sustainable basis is going to take a couple of years. So we need to agree the investment, redesign the models, recruit staff, and get new enhanced services up and running. So we're probably nearly at the beginning of the journey there, but it's a point I think that's at least very well recognised now in the system.
Thank you, Rob. Thank you, Matthew. Just to say how well recognised it is, Colin, for information, Robert and I this week attended the ICB board meeting, and Children and Young People Services was the subject matter for a deep dive. So it's recognised wide and far, but as Matthew says, quite honestly, we're at the beginning of these improvements with the new investment, but and it's been a running theme within our board, to be fair, Matthew, I think, and we'll continue to receive updates on how we see those services hopefully improve. Sue.
Yes, so Jill and I have visited both paediatric speech and language therapies now, and the balanced system that they are working with is working very well for them, and it's just how we can hasten the rollout of that with other services which are interested but haven't yet done the work that they've done to get it going.
Yeah, so we've got commitment from Chair, did you want me to answer? Yeah. We've got commitment from the ICB for 2 leads to roll out the balanced system in physio and occupational therapy. We've got 1 lead in place. We've begun the work in physiotherapy. It's easier to work through balanced in physiotherapy than it is in occupational therapy, because you can quickly get going with some initiatives which we have done, such as starting group education programs for children who have common problems. So I'd say, we've already started with a balanced program in physiotherapy, and we've started to see some initial good signs of improvement. So when we look at waiting list numbers, actually we started to see that ease over in physiotherapy, and we're actually quite optimistic that physiotherapy and occupational therapy weights will be among the first to respond because we've already begun the balanced programme of work with system partners.
Thank you, Matthew. Anything else on Robert's report at all? Comprehensive and some good informative stuff there, Robert. So thank you to you and the team who put that together. Okay, if we could note that then, please, and then move on to the board assurance framework and high-level risk register, an area which I think is fair to say is quietly undergoing quite a lot of work, and will come to board at a higher level in I think it's next month, if not the month after. Jill.
Yes, so probably each meeting you probably see a slightly different iteration in terms of how we're presenting and how we're trying to more explicitly show the risks under each of our strategic objectives and what are the programmes of work. So I don't think we're quite there yet, but I think we are making some progress. I think we're also making progress in terms of how risk is being managed generally within operational services, and it feels really quite positive when I'm meeting with the SDU leads in terms of how they've embraced a different approach to risk management, and so I think that is a very positive story. Obviously, this will be subject to review, and our internal auditors are going to do a review about this a bit later in the year. So there will be an independent review as to how we've embedded the risk management work and whether it's actually making a difference. In terms of what you've got before you, I start off just by identifying the higher level risks, and one of the things that we are trying to embed within the risk management process generally is that sometimes risks might need to be escalated not just based upon scoring, but we might have something which is a potentially rare event but potentially catastrophic, and we might then need to escalate that, albeit it has a relatively low score. And so that is something that we're discussing with the SDU leads. And so when we identify the risks that are escalated, the majority of those are always going to be escalated based upon scoring, that is, looking at potential severity and likelihood. But there are also, we are having discussions about, are there things that need to be escalated because you're no longer capable of managing them within your SDU or within your service, and we might need a different approach to that. The other thing that I'm hoping that the new look board assurance framework is seeking to emphasise is about what are we doing under each of the strategic objectives to address the risks that are identified, and how are we moving forward on the strategic objectives. And that's through the priority programmes that we've obviously identified in respect of each of the areas. And what you'll also see is that this links into Sue's next paper in terms of what progress are we making, and through the management of those priority programmes, how assured are we on those? And so you'll see for each of the strategic objectives a list of what are the priority programmes and what are the assurance levels. I think the one thing that we need to do a little bit more work on is then about what risks are coming up through those priority programmes to actually complete that picture. So, as I said, this I think remains work in progress at the moment. We do have in November a development session about risk management and use of the BAF at board. But I think if at that point I'll just leave it there, and happy to take any questions, although it may be this, for details of specific risks, I might need to look to executive colleagues to address those.
Thank you, Jill. Sue.
Yes, I think the work in progress is commendable. I would just like to say that I think there also needs to be a space for risks which our trust knows that it's not commissioned to deal with, but it also knows that no one else is commissioned to deal with. And that comes out of a visit to dietetics when they identified a group of patients who would have no service. So basically, the community doesn't deal with people with dietetic needs in care homes, and nor does acute. So we said, well, what do you do about that? And they sort of shrugged, as in they knew that it fell through the cracks, but they didn't know what to do about that. So I think Denise was taking that forward, but just, because people on the ground will know these things, but they might not know where the space is to raise them.
Okay, thank you.
Thank you, Sue. Lisa.
Thank you, Chair. Just to note, the board will see the addition of a cyber risk on the BAF at this point. We've had a high level risk on the digital risk register at a 16, which is mitigated down to a 12 due to the recent obtaining of DSPT and Cyber Essentials Plus. But Jill and I felt that given the heightened levels of cyber disruption, it was good to have that level under the efficient and effective strategy for the BAF.
Okay, thank you. And of course, cyber risk is ever present, and there's not many weeks go by when there hasn't been some sort of cyber risk or actually attack reported in the press somewhere in there. Okay, if there's nothing else, remind board that at the end of the meeting we will return to the BAF to check if anything has come up today in our discussions or within our knowledge that we think should affect the BAF or indeed high-level risks moving forward. So we will return to that at the end of the agenda. So thank you, Jill, and we look forward to the November session where we can get more sort of deep dive into it. And we need to agree the BAF as it stands now. Do we all agree as presented today by Jill? I see nothing contrary. So yes, thank you, Jill. All agreed. We move on to the linked trust priority programme. Sue.
Thank you, Chair. And just to clarify, really, hopefully the board will now feel that sequence that we're layering in. So very much now this being a composite overview of all of the priorities we've set across the whole organisation as a board, and very much linking back then to the conversation we've just had around the BAF. So whilst work in progress, I think this is the first time that we've seen this report where we put an assurance level on every single priority. We are obviously still evolving that, and as a board we're moving forward in making sure that we're really clear what sits in the improvement plan and what sits in programme management board and the committees. But this is the paper that brings them all together, because this is what we as a board said we wanted to focus and have a real line of sight on for 24-25. So it got our 5 strategic priorities, and so the assurance levels have now been assigned since the last time we looked at this in July. Just to pick up some specifics, I mean, hopefully it gives you everything you need. I wasn't going to go into any detail other than where I think things have changed or I need to highlight specifics. So we've just picked up about community paediatrics. There is a lot of work happening both in the system and internally to unpick the work programme that we need over the medium to longer term. So we've just heard about the work happening around SEND with the waiting lists. We've also got the work we're doing with the system around the neurodevelopmental pathway, and that's a kind of more medium sustainable piece, but it all interfaces with the work we need to do anyway in our community paediatrics service. So my programme management team working really hard with Matthew and the SDU leads and clinical colleagues to really nail down how those pieces come together with some immediate sustainability actions, as well as a really clear programme of work for the longer term. We've also got continuing work on the adult mental health acute inpatient rehabilitation redesign. So just to make you aware as a board, over the next month, we will be looking at the desirable criteria and doing that further options appraisal and analysis. So that's coming through to board. So that's another really important checkpoint, the development of that particular pathway and the work we're doing with NHS England around the business case. And we also now have a gateway process meeting put in with NHS England to give them an overarching view of where we are and the timelines going forward. The other piece as well is we're now picking up the improvement plan in this sequence that we look at now in the board agenda. So we've got the overarching piece of the improvement plan, but the details sitting elsewhere. But it just shows now that, at least within my report, we can see end to end of all of the work that's a priority sitting across the organisation. And then finally, I just wanted to pick up on the ARISE programme, really important piece of work for the board and across the organisation, and we're doing a reset there to make sure we're really clear on the elements around recruitment and retention that are feeding into the programme management board, and in particular making sure we do the further work on the trajectories and the closing of that vacancy gap, which we know is an absolute critical priority for the board across 24-25 and into next year. So hopefully I welcome feedback on the report, and some elements I might have to ask executive colleagues to respond to. But yeah, that's what I wanted to pick out today, Chair. Thank you.
Thanks, Sue. Martin and then Janet. Martin.
Yeah, thank you, Sue. I love the format of the report. It's developing nicely, and the two together works really well. Can I delve down into a couple of specifics, though? Perhaps you could answer something around 1.4 in terms of the neighbourhood team resource allocation. Exactly what we mean by levelling down, and how that will be done in the context of quality impact assessments and equality impact assessments, as the first question. And then the second one is a slightly related one on 4.2 and 4.3 around the frailty programme and virtual wards. Really, the question is, who is in sync with what the JSNA and the priority needs say? Because I thought frailty was on the JSNA as the priority need, for an area to say, actually, we're not going to do that, we're going to do diabetes. I'm just wondering where we sit. Are we out of sync, or is that local area partnership out of sync?
Thanks, Martin. And I think I'd want to bring Rob in here, Rob Cunningham, because this is a very live conversation. There's been more conversations this week around the frailty pathway and the work programme. Just to say around the levelling down, there's been quite a lot of work putting in some health inequalities data, actually, Martin, to triangulate to see if there's not going to be significant increased investment, and we are in a challenged financial system. Was there a potential to redistribute what we've got, which we know is also very challenging? But Rob, I know that you picked up about the virtual wards. Do you want to just come in on that whole work programme?
Yeah, thank you, Sue. And I think I'll just pick up on both points, if that's okay. So the levelling up, levelling down discussion, colleagues may be aware that we've got quite a significant variation in our workforce across our neighbourhood teams. We've done some comprehensive work, or I should say, or reference Kate Pike, the Associate Director, has led on a comprehensive piece of work to get under the bonnet of what the resource allocation looks like. And that takes into account multiple factors: population sizes, care home numbers, geographical spread of the patch that the neighbourhood team's covering, as well as demographic profiling, population, age, etc., working very closely with public health on that matter. I think additionally, our proposal, when we were looking at developing our frailty virtual ward, there are components of the original virtual ward proposal in relation to increasing our senior clinical decision-making workforce, which is absolutely key to the virtual ward model. So particularly ACPs, and then what does medical oversight look like, either from primary care and or opportunities for outreach from the acute hospital. As part of that original proposal, we also considered and suggested, included in the proposal, levelling up opportunities to the ICB. Affordability is an issue, and we've been asked to remove the levelling up component from the virtual ward, so we separate those. Where we're now at is discussions with primary care around what does the fair spread of the resource look like across the whole of the county. We've got the variation in place due to historical funding arrangements, I believe or understand, due to 3 CCGs covering Worcestershire, so we've got an inequity. So there's a process that needs to continue through with primary care, with ICB, to look at what the fair spread of resource needs to look like. If there are instances of levelling down, that there are services that have got higher resource and we need to level that resource down to other areas that are under the average, then absolutely we will need to go through the quality assurance processes to support that.
Thanks, Rob. Thanks, Sue. Janet.
Thank you. I wanted to ask about the rollout of the clinical strategy and whether I've read this correctly, because if so, I was a bit disappointed that actually, although we've got 30 new teams ready to go, we're actually pausing because we need an analyst. Is that correct, or have I got that wrong? Because I think if it is correct, I think it's we're missing an opportunity here, because I think the clinical strategy implementation is fundamental.
Is that John, Sue?
Yeah, so I'll just start off and bring John in. But yes, at the moment, we've gone out to the University of Worcester because the requirements around the 30 teams have proved to be quite significant. We've learned from experience, Janet, if we don't have that analytical capacity, we end up down the road not being able to potentially really take the teams with us on doing something quite different, because we want them to own the data from the outset. So better to make sure that we've got the analytical capacity before we take the teams too far down the road without that. So the university had been approached to provide additional capacity above and beyond the evaluation, and I was waiting this week to find out whether that's been secured. But the teams are ready, they've had the training, they've had the overview, so it's a case of pushing the button. John, is there anything you wanted to add as SRO?
No, I think you've covered that, Sue. Thanks.
Can I come back and just ask them, do we have a plan B if the university says no?
I believe the meeting happened yesterday, Janet, and everything is on track with regards to the university are really keen. They're very keen to get involved, so they're very good partners with us around the clinical strategy.
And just to say, Janet, as well, to have the local university doing the evaluation is really powerful as well. We had it from the commissioning support unit previously. I think this is going to feel much more comprehensive, and I think it gives us a really good platform then to rolling this out, because this has been a slow burn and I'd like to see it gather pace in 25-26.
Sounds, Janet, like Plan A is still intact, which isn't always the case. If I may, I have one question and a comment I'll offer. And the question is somewhere between Sue and Matthew. Matthew, I noted you said in an answer previously there's an injection of investment into our children and young people services, which obviously is great news. But whenever we have an injection of investment, rightly, we want to see it go to the front line to deliver more or better services. But equally, there's always a need for support to those new or improved services, including PMO and things like that. Is there enough resource to support this area of development in the background?
I think respectfully, I've got to say that there probably isn't. We've got a management team that is kind of feels like they're fighting a war on all fronts at the moment. That we've got some very challenged services which we're trying to improve. We've got new investment which we're trying to roll out, and we've got obviously services which are under direct award for contract, which again need to be mobilised. So it feels very stretched. We're having some discussions amongst the executive team at the moment about how to support that more with some additional PMO resource, but as of this week they haven't quite landed.
Okay, Sue.
Yes, just to say, I think that it is an SDU at the moment which my directorate is prioritising. So we're looking at some of the other PMO programmes. So as we've just heard, some of the work around the virtual ward rollout has slowed down because we're waiting on decisions. That enables me to lift and shift some of that capacity to wrap around Sonia and the team. I've also moved some of our business planning, so Mark's Medley in the main, to be working predominantly now around the business case. He's put a lot of capacity in around the 0 to 19. So Mark, it's a very dynamic situation, and we're doing everything we can to bring in the corporate resource where some of the challenges, we're asking the same people for the same information and questions, which is obviously what we want to try and reduce down, because they've also got the day job to do. So yes, the PMO was reset to act as a dynamic resource to wrap around the priority programmes, and each time they shift, I sit with the team and we look again, and we do that work hand in glove with Matthew. So that's a sort of shift that we've started on this week to make sure we've got what we think's needed, and we'll keep that under review.
Thank you, Sue. And please, you're coming in, Rob, because I was going to ask you to keep an eye on this. So, Rob.
Yeah, I guess there's a couple of things in here, really, aren't there? The first one is that there continues to be an ongoing challenge about, overall capacity and pressures to deliver the priority things we need to do, and obviously that's a difficult discussion that we have around what we prioritise and how we resource that. So some of that, or a lot of that, is about how we mobilise existing resources we've got within the organisation against those priority areas. Some of it, as Matthew alludes to, is we need to put in some additional, potentially fixed term support to some of those areas. So those are live discussions, and we will keep having that. I suppose I'll probably refer you back to the Darcy report that does talk about an underinvestment in management resource generally across the NHS over a period of time. I suppose the other one, which is probably the more specific one, is as a point of principle, we look for investments that are fully absorbed in terms of a costing. So that does cover a contribution towards indirect and overhead costs, but clearly that's not going to resolve where we've got specific pinch points, and that's about organisational decisions about prioritisation resource. I would say I don't think we've always been the best at prioritisation and focus in the past, and that's something that we're trying to get better at, but it's not easy. So there's a few things going on. In terms of the investment, just to be clear, that will formally go up through our governance routes in terms of committee and so forth, but it's just a very live conversation and discussion at the moment. So that will come through in due course.
Thank you, Rob. That's the assurance I was seeking, that it's you and the team, your executive team, are on the case and recognise the issues, which clearly you do. So thank you. Sue, thank you for this report. Thank you to, I know Mark and Matt and others are behind the scenes, but I feel now we're getting into a position where two things: we're getting the information we need in the succinct clarity in which we need it. It's not dressed up in any way. It gives us what we need without dressing up things, and giving us with that honesty and integrity, which I know it's a developing report, but I really do think we're getting somewhere now with that. So thank you very much indeed. If we could then note Sue's report, and if we could then move on to Matthew's operational update. Matthew.
Thank you. Just to start us off around industrial action generally, GPs are continuing to operate a collective work into contract. So just a reminder, GPs aren't directly employed by the NHS, they're contracted. So in a sense, they can't go on strike or take other industrial action, but they're working to the terms of their contract. And that has various measures being undertaken by GP practices across Herefordshire and Worcestershire. These are monitored on a daily basis by the ICB. I've said at the moment, although individual patients may have felt the effects, there's been no noticeable effect on other parts of the health economy. GPs are in discussion, the BMA GP collaborative are in discussion at the moment about balloting for further, more extensive action, possibly starting as early as November. Obviously, good news, the junior doctors have settled now, so we look forward to, we hope, a winter without further major industrial action. We've got continued challenges around our acute mental health beds. The underlying reasons remain the same as they were at the last report, which we've got large numbers of patients waiting for housing and care packages, sometimes quite extensive and sophisticated packages of care that require various funding streams. At the moment, as I speak, 40% of our acute mental health beds are occupied with patients who don't need to be in a mental health bed today. Actions are ongoing. It's a daily discussion. I've asked for an additional focus from clinical teams on balancing risk. That is to say, to take different risk decisions about care that could be undertaken with patients in their own home, even where it wouldn't be optimal conditions that they're returning home to. Very much the same discussions you have to have in acute physical health hospitals every day. In terms of out-of-area placements, we're still managing to keep the majority of people fairly locally placed by good relationships with independent providers in this region of the Midlands. Following on from the mental health homicide in Nottinghamshire and the following CQC Section 48 review, the NHS is reviewing the sufficiency of mental health provision for people with psychosis who are at risk of disengaging with services. That's a system assessment ICB by ICB using what's called a maturity index tool. So our teams met with system partners at the end of last month for an away day, going through processes, teams, how we dealt with patients, really to self-rate for the assessment. The system will be making the submission at the end of September. It's been reviewed in directors this week and we'll go through a mental health collaborative executive. Very short timelines on this. We were only issued with the template in the last week of July, so we've had August to do it. Has to be submitted in September. At the moment, it's not, it's a formative submission. So the NHS appear to be using the data collected to understand how to set further policy, which I hope will include policy around investment in this area. Because as you're probably aware, over the last 10 years, 15 years, specialist mental health teams for people who may be disengaging haven't generally been recommissioned. So we'll await further guidance from NHS England. We think that the national return are likely to show a wide variation in practice. On SEND, we've now as a system submitted our priority action plan. Focus for the trust is on reducing waiting lists for physiotherapy, occupational therapy, and mainly neurodiversity assessments. In the SEND report, it talks a lot about paediatric waiting lists, but the children that are waiting are mainly waiting for autism and ADHD assessments. We're in ongoing discussion with system partners, as I've said, about further investment and redesign. We've commenced some waiting list initiatives, and we've agreed additional sessions with paediatricians, a couple of external people coming in as well, and some insourcing and outsourcing solutions. All of these are aimed at freeing up paediatrician time to undertake neurodiversity assessments. We've also commenced a job planning initiative. So John has been working with an external partner who's come in and working with our paediatricians to reset job plans and standardise some work plans and align those to service needs. In terms of speed of outputs, our belief is that AHP waiting lists, that's physio and OT, those will improve relatively quickly. Balance system takes a long time, but we've got some early wins that we feel, okay, this is going to make things move. For neurodiversity waiting lists, we will see improvement between now and April. We think the improvement is more likely to be modest, so in the 20-30% range, and it's going to take us a couple of years to set the service back on a sustainable footing, because the imbalance between the demand and our capacity to meet that demand is really so great. And only this week, the ICB has produced their outline specification for neurodiversity services for children. This has been 2 years in the making. So the ICB are working on neurodiversity services for children since March 2022. And myself and Sue have got a meeting with the ICB leads on Monday to talk about that further, including how quickly we could respond to an invitation to tender for an extension for those services. System-wise, one of our big focuses has been obviously around winter planning. The focus of that presently is on meeting the new 45-minute ambulance handover target. We had a special urgent and emergency care board yesterday. It's an extremely challenging aspiration for this system, which is one of the most difficult in the Midlands to meet the 45-minute handover. And that's for the various historic reasons and building design reasons and ambulance flow reasons, but it's going to be very difficult. Work for our trust is focused on continuing to improve the single point of access, ensuring that out of hospital alternatives are increasingly available and as well joined to the single point of access they can be, improving community hospital flow with social care partners, so making sure that people who need to leave community hospital can in a timely fashion to allow people to leave the acute and move into community hospital, and working with acute and general practice leads around developing the virtual ward model and the frailty pathway front door at ED. So all that work is being overseen at Urgent Care Board and is subject to a system plan. Just some news on Evesham Hospital. We had a minor ceiling collapse last month. It was well managed. Well, as much as you well manage a ceiling falling down. But there's no staff or patient injury. We have had a site survey undertaken, which has revealed areas that require immediate repair. One of those is a patient area. So we're operating with 8 fewer physical beds at the moment. That doesn't mean we're down a capacity of 8, because we've mitigated that by better pathway management and use of beds appropriately on other sites. There's been no impact on the stroke pathway so far. I think we need to all note as a board that the age of Evesham Hospital and its general condition means that further major problems are likely going forward, however well we manage the site.
Thank you, Matthew. And on that cheery note of truth, to be honest, having been to Evesham this week, we'll move to questions. Sue and then Janet.
The first is a comment, and I noted it down when with regard to Robert's report, but I would just like to congratulate the fact that the SPOA and the UCR were used as the case study by the, I think it was the Department of Health, was it, or the Cabinet Office? I thought that was very commendable. But the second is a question. Keeping Children Safe in Education 2024 emphasises early help far more, and obviously we're aware that maintained schools are going to have mental health leads in them, or that was the policy that was going to be formulated. Are we expecting therefore more issues to be dealt with at school level, or are we still thinking that things will be moved towards the ICS part of the Health and Social Care Act?
Thank you, Sue. There may be detailed aspects about that question that I'll need to return to you on. I mean, in general terms, there's a couple of things around that. One is in terms of trying to keep things at school level. Part of the work of the balance system is around work with education partners to ensure that where children can have adaptations at school and other people can be enabled to provide aspects of care and well-being for children, that we're enabling that as much as we possibly can. In terms of mental health support for school, we've got a couple of things going on initially with our WEST program, so our wellbeing and emotional support teams in schools program. That's now rolled out to 60% of schools in Herefordshire and Worcestershire, and we're entering a new phase to roll out further. So we're working very closely with schools around that, and also around our transition team that works between schools and CAMS as well. So we've got things going on, but with regard to your specific question, it may benefit from further detail from the service, which I'm able to supply outside of the meeting.
Thanks, Matthew. Janet, then Vina. Janet.
Yeah, I wanted to go back to the Evesham Hospital and the roof, because I just wondered about, I think the report says that the ward will be closed until mid-September, and by my reckoning that's now. So it was just, when do we think it's going to be opened again? But the bigger question was that we all know, don't we, that Evesham Hospital, and you said it yourself, it's not ideal, and we have tried to bid for money to have it replaced, and I'm thinking, as a board, we sit and listen and hear that this has happened, and wonder whether we should be having some more detailed planning about what we're actually going to do about that site, or at least plan to have the planning, because this has happened and it won't be long before probably something else happens. So it was just, do we have plans to have plans?
Well, Robert's probably got a very specific answer to that, so it might be that I bring him in first. I would say initially, though, that we are probably at the point where we cannot avoid very soon having some discussions about which capital investments are going to be worthwhile given the need for them and the overall lifespan of the hospital.
Thank you. Robert, are you going to comment on Evesham Hospital, please?
Yeah. So, Janet, I suppose it's just worth the board recalling, or for those newer members of the board, just to kind of set out where we are. We did do quite a detailed outline feasibility scheme. It was just pre-COVID, which we used as part of our bid for the new hospitals programme. And we know the new hospitals programme run into all sorts of problems, and we had a lot of active support from the local community, but particularly from our members of parliament. I did speak to the local MP at the back end of last week just about where we are, just to brief him in terms of Evesham, and there's definitely an appetite to draw together a new plan. The issue with this is drawing together a new plan is one side of it, which will take a degree of time. There's also then, this has to be teamed up with the national policy actually about what is the strategic plan around infrastructure. Now, that's part of the Darcy report, chronic underinvestment in capital over particularly the last, I guess, 8, 9, 10 years. And there's also a review and reevaluation of the new hospitals programme going on at the moment. So this is going to be an element of, we're going to have our local contingency plans for around how do we keep things running for realistically the next few years. Hopefully, alongside that, a strategic solution could be brought together. But I think, eyes wide open. This is not the only piece of significant infrastructure across the country that is struggling. So we're absolutely working on that basis, Janet, and there's a lot of a lot of goodwill and I'd say ambition around this, but it's not going to be a short-term fix. I think the point Matthew draws out is important, in that the consequences, this is going to impact on our capital programme for the next few years, and actually how we prioritise that. It's maybe something that Denise will draw on a little bit later, but that's definitely one of the consequences. And on the very specific point, we've had 2 issues in the same ward at Evesham. So the ward is split into kind of 2 legs. The one side has been fixed. We've now got an issue on the other one, which is the one that's going to run for longer, because it's going to be more extensive remedial works.
Thanks, Robert. Vina.
Yeah, I'm also worried about Evesham, and thank you. You've actually answered part of the question I was going to ask, but also, if we've already had, I love the oxymoron, minor ceiling collapse. If we've already had a collapse of a part of a ceiling, we've spotted an issue on the other side of the ward. It feels to me that we're on notice that there is a possibility of further issues. So, yes, funding for new hospitals, etc., isn't going to happen overnight, but Can we assure the public that, you know, we have got our health and safety obligations at the forefront of our minds, and we're putting in place, you know, the checks and making sure that we're alert to this stuff happening before it happens?
Yeah, I mean, I might draw Denise in, but I can absolutely assure you, Vina, that is what we do. That this is what we're experiencing is just the consequence of a time life expired building. You know, for a building dating from the 1930s, which we're still running. You can have a very good preventative maintenance scheme. You can do all the checks and so forth, which we do. But things just do fail and wear out, and it's often the things that fail and wear out from the inside. So pipe work that looks absolutely fine from the outside will corrode away from the inside, and then you know problems will manifest. So we're absolutely doing all we can, but we shouldn't be unaware that, you know, this is very old infrastructure which is past its useful life, and we need a solution to that.
Denise, were you going to add some flavour to that?
Yes, I was. Thanks, Chair. So, Vina, we're just going to say that at the moment we have got specialists going out to the hospital, and various reports are being drawn up to sort of assist us with any, you know, further works that we need to do. So that's already in progress.
Thanks, Denise. Colin.
Thank you, Chair. I would like to go back to Matthew on the comments you made about encouraging clinicians to take a more flexible perspective of risk when looking at discharge. And that seems an eminently sensible thing to do, and hopefully will be productive. But I wondered how the organisation supports those clinicians, because it must be quite a dilemma for them if they know the right thing to do is to get the patient out back to where they most ideally would be, but there's always the risk that something nasty will come along and bite them.
Yeah. The specific encouragement that we're giving people. So myself and John have met with clinical and operational leads to provide some support and guidance around this. The specific encouragement we're giving people is to think about what challenges the person came into hospital with, to which a hospital cannot provide a solution. So a lot of people come in a difficult social circumstance, and that could be supported to be resolved at home rather than waiting in hospital until that social circumstance is resolved and then sending the patient home. So myself and John have expressed our willingness to continue supporting. We have a kind of a clinical summit system as well that can be called upon in times where additional decisions need to be made. So there may be a multidisciplinary group called together with medical and operational leads to help frontline clinicians make balanced risk decisions. That's something we do from time to time.
Thank you, Matthew. Okay, if there's nothing else, thank you, Matthew, for that report. And I think the Trust Priority Programme is what we think we should be doing. The operational update is what we are doing. And the improvement plan is what we're going to do. And so it seems like by fluke or design, that's the way this section is going. So if we can note Matthew's report, please. And if we move on to the improvement plan, Scott, but in the full knowledge that a month from now, we'll be having a significant deep dive into the whole of the improvement plan and spending a morning or an afternoon on this subject. So if you could just draw out anything that you think we need to know before that deep dive, and then once you finish, we'll probably take a short break. Scott.
Fantastic. Thank you, Mark, and thank you for the introduction. So I just want to start with just reminding colleagues that the improvement plan is built upon the feedback from our staff. So over the period of the last 12 months, over 1,000 staff have had the opportunity to feed into what the issues are as they see them in the trust and what actions they'd like us to take. Those actions are enacted through 6 exec-led work streams. And I just want to give my thanks to colleagues who are on this call for their focus and effort on delivery of the work. Within the report, we discuss the impact monitoring, and that is via our Pulse dashboard. That's accessible to everybody with the report there, which just gives the opportunity to really understand what staff are saying, how they're feeling, and the progress that we're making with the impact of the improvement plan. When you have a chance to look at it, there's some real clear areas where we're making good progress, but also it's important to note that it is still early days, and when we get round to that board session, a lot of the focus there is going to be about really embedding and sustaining what we've done so far, where we think we need to do more. A couple of bits I just want to pull out. This last month, board will note that we've relaunched the face-to-face induction, which has been received very well by staff and managers. So it was a really good piece of work there by Elaine and her team. We are also launching the induction, the managers program, so managing and leading together. That program has been reviewed at Workforce Committee and actually launches during September. So again, that's something we're really, really pleased with, that what our managers have been calling for is being delivered. As you know, we've also been doing a lot of work around our integrated governance. We're now going into phase of review of the effectiveness of that governance. And I have to say the key headlines from that, the work that Jill's already mentioned around risk, you can really see that embedding. Staff are feeding back that they are the effectiveness of the governance. There are some real positives in there. Again, real credit there to Matthew and Rob as chairs, Natalie and John, who have been heavily working in that space as well. Couple of areas, though, that we do still need to work on there is about making sure feedback comes back down through those groups, and also data. But that is one of the areas which we'll be picking up in the October session. So overall, those are the things which are working and heading on track. The one area that is off track, though, is around our move towards a resolution policy. As a reminder, this is the mechanism for how we can support staff to resolve issues at an early stage. Now, there was reviewed in detail at the Workforce Committee. The latest progress is the procurement exercise for the external partner is now almost complete, and staff are helping us choose which partner it is we're going to work with. As a reminder, they'll provide us an outsourced solution in the short term, while supporting us to train mediators, coaches and facilitators internally within the trust. Again, we'll cover that off in more detail, obviously, in the October session. But overall, that's the overview of where we are with the report. And we will do the full detail in the October deep dive.
Thank you, Scott. And I think your report is concise and clear as well, so thank you for that. Anybody have any questions at all about where we are? Okay, I think most people seem comfortable, Scott, but like I say, we'll probably give we definitely will give the tyres a good kick in exactly 4 weeks today, when we come together to look in detail to check as a board we're satisfied that the progress we're making is as we anticipated and as we desired. So can we note that report, please? In which case, if we could take a 10-minute break, I would suggest, and if we could come back at 5 to 11, please, 5 to 11. Thank you.